Hi everybody, welcome. Thank you so much for joining me. My name is Lindsay Adams. I am a registered nurse at a small community hospital and I work on a medical surgical floor. And I'm currently in the program to receive my DNP through St. Augustine University. And today I'd like to share with you my PICOT presentation that I have been working on this semester. So thank you so much for joining me. I'm going to go ahead and get started. Just a quick overview of the things I'd like to discuss today. So I will be reviewing my practice gap that I identified in my work environment and how I developed my PICOT question. I'll be reviewing the evidence that I researched and found after identifying my question. The change model that I've identified to use to make these changes within the environment, and how I will evaluate the data that I receive back from those changes, and then how I will disseminate that information and get it out to you, to my work environment, and across the nation. And then I will wrap it up in a conclusion. So my practice problem, as I said, I work on a med-surg floor and we receive very many COPD patients. So they're frequently in the hospital for admission, and if they're not there for an exacerbation, it's another issue that they're having. So COPD is a disease that is characterized by limited airflow and a steady decline in their respiratory stamina and their function. So these patients already, for those reasons, are at increased risk to develop pneumonia. The medications that they're on, like their inhaled corticosteroids, will put them at increased risk for pneumonia. And that limited airflow, of course, they're not able to expand their lungs like a normal healthy person, so that puts them at increased risk to develop pneumonia. The mortality rate and the outcomes for these patients are not favorable. They often end up having a more severe case of pneumonia than non-COPD patients, and they have an increased frequency of admission to the ICU if they do develop pneumonia. And then in addition to all of those things that make them at risk for pneumonia, I also identified that the vaccination rates for these patients are suboptimal, and that can possibly be related to a lack of awareness that this vaccine is available to them. So all those things kind of led me to this problem of these patients should be vaccinated for pneumonia if this can potentially help them. And on my floor, we've actually recently switched our electronic charting system. So prior to this, we had a screening for influenza and pneumonia. So when I sat down to develop my practice problem, it was the beginning of flu season, and of course on a med-surg floor, all we heard the entire month was, don't let your patients escape without the flu shot. And that got me really thinking, why did we do away with our vaccine screening for pneumonia, and why have we stopped offering, educating, and administering that vaccine? Some of the answers I got back to that information were just that, we can defer that to a primary care physician, but this is such a high-risk group and unfortunately can sometimes be a little famous for being non-compliant. So maybe they're not going in to their primary care as often as they should be, and they don't have the opportunities to hear about this vaccine. So it didn't make sense to me that we are pushing that off on primary care when we have a great opportunity while they're in the hospital to screen them and administer that vaccine if they are consenting to it. So all these things led me to my PICOT question, which I have here for you. And my official question was, in patients with COPD, does receiving the pneumonia vaccine compared with not receiving the pneumonia vaccine prevent pneumonia over the course of a year? And I did choose 1 year because I wanted to catch all of the seasons. I know that we most often see them in the fall and the winter, but we do have them throughout the year. So if we can get a screening done anytime, any season, that would be great. So I did choose over the course of a year. This is just some of my search information here. So with my PICO question in hand, I headed to my databases. I used PubMed and Google Scholar with the keywords COPD, pneumonia, vaccine, and prevention. That yielded me 165 articles, and had to remove some duplicates, filter through that, added some inclusion criteria that I only wanted articles that were recent, so I included the years between 2014 and 2019, and I wanted them to be peer-reviewed articles. And I excluded some criteria as well. So a lot of information out there about influenza and pneumonia vaccines as dual vaccines, but I just wanted to purely focus on whether the pneumonia shot would be beneficial and effective in preventing pneumonia. So I went ahead and excluded any articles including influenza. The vaccine is focused on prevention for community-acquired pneumonia, so I did exclude any articles that discussed ventilator-associated pneumonia. And then I wanted to only focus on COPD, so I did exclude some other chronic lung conditions like asthma, interstitial lung disease, that kind of thing. So those were excluded from my search. And at long last, I ended up with 7 research articles to include in my project. And here's my evidence for you. So some interesting things that I found, I've just kind of highlighted them here for you. One particular study found the vaccine was effective in preventing 76% of patients with moderate COPD and then 48% of patients with severe COPD. And to me, those were huge numbers. Of course, that was just one particular study's number, but if we could expand that across the COPD population and get anywhere near those numbers, it would be a huge benefit to these patients. It also reduced the number of ER visits and inpatient admissions, which is a big deal for several reasons. Of course, we're avoiding pneumonia and any sequelae that would come with that in a COPD patient, but we're also keeping them out of the ER and keeping them away from other sick people. They, if they don't need to come to the ER, then they're maybe avoiding somebody that has influenza, any other disease that they could end up catching while they're in the ER. So that would be beneficial for the patient. We're also preventing the incidence of exacerbation, which I found was very interesting, because anytime the COPD patients have an exacerbation, they're losing a little bit of their lung function. So if we can sustain their baseline lung function for a little bit longer in between exacerbations, these patients will be receiving a great service. So reducing pneumonia incidence and possibly reducing the incidence of an exacerbation would be great for these patients. Of course, those are all health benefits, and one interesting thing that I found was the financial benefits. So these patients already have an expensive disease. The inhalers that they use are very expensive, several $100s a month. Unfortunately, many of the new ones that they should be on are brand name, brand new, very expensive. They're paying to see a specialist, a pulmonologist, and then on top of that, sometimes hospital admission or ER visits can't be avoided. So those are all financial burdens on these patients, and if they can have a vaccine that's going to reduce potentially the number of visits they take to the ER or will avoid a hospital admission for them, that will be a huge financial burden lifted off of their shoulders. And also, there's a financial strain on the healthcare system for these patients. They're frequently readmitted to the hospital. So if we can do something to help avoid some of those admissions, it's also going to be a great economic benefit to the healthcare system. And then finally, to switch gears a little bit to touch on education, one article found that nearly 40% of patients had not received any education on the vaccine, but those that had an 85% compliance rate. So these patients want to do something to prevent their disease from progressing or from having any complications, and they need to be educated and aware that there is something out there that could help them. So the change model that I would propose using would be Berwick's model of change. just to touch base on a few things, I would definitely want to find early supporters and early adopters of the process to screen and vaccinate these patients. And fortunately, at my hospital, we have a clinical practice council, and these are people from all over the hospital, every unit, inpatient, all the departments, and they focus on evidence-based practice, what we're already doing, and what we could be doing. So this would be a great chance for me to gain some support for my project and to send them back out into the hospital and making their behavior observable on their units, so I can kind of recruit more and more people to be supportive of this change. And then also just making sure to step back and take some constructive criticism, what works best for the workflow to get everybody to participate in this project and to screening these patients. And then, of course, leading change through myself also, just sharing the information with the patients and really all of the staff, that we can be making a difference and what the difference actually is. So for my analysis, we have a great informatics team that can pull all of the information for me on their screening tool and their subsequent admissions for pneumonia. So with that nominal data, I can use a chi-square test to evaluate for significance. And then once I have all of that wonderful information, my plan for dissemination is here. So of course I will be taking back that information to Clinical Practice Council. We're also on a journey to high reliability, so we have been doing a safety huddle with management and administration every morning, which would be a great opportunity to present this to them and get the management support and have continued support for the project. Reviewing the information in annual skills is another great opportunity to get it out there across the organization and to get feedback on how that's working. And then the organization also does a conference every year for all the units to present their projects for improvements throughout the organization. So that's a great opportunity to get everybody involved. And then regionally, we also have the Virginia Nurses Association, their spring conference, which would be a great opportunity to present a poster and get that out to the state of Virginia. And then nationally, Sigma Theta Tau, the Nursing Honor Society, has a journal that they publish, which is a great opportunity because they're big proponents of evidence-based practice, and that would be a great opportunity to nationally publish this information. So, to summarize here, my practice recommendations after developing my PICO and doing some research and making a plan to enact this project would be to screen these patients. We need to know, have you heard of the vaccine? Have you had it, and would you like it before you leave the hospital? Particularly focusing, of course, on this high-risk COPD patient population. The screening would be for everybody, but we definitely want to catch those patients with COPD because we want to educate them. We want them to know all of the benefits that I have reviewed here. Not only are you avoiding potentially pneumonia, you could be avoiding COPD exacerbations, you could be avoiding ER visits, you could be saving money. So educating these patients and making them understand the true benefits of receiving the vaccine. And then actually vaccinating them. So we want to make sure that if we screen them and if we offer this to them, that we are administering it before they leave if they want it. We have a hard stop for a flu vaccine, so that needs to be in place for the pneumonia vaccine as well. If you want it before you leave, you should definitely get it. And here are my references on this slide. And if anybody has any questions or comments, suggestions, please feel free to leave a comment below. I would greatly appreciate it, and I would be happy to answer. And thank you so much for joining me, and have a good evening.